You, now, you tell me when you're ready to start, Dina.
We are ready for you to start your presentation.
Okay, all right. Hello, everybody. Thank you for having me. My name is Carol Gormley. I'm Vice President for Government Affairs for Independent Living Systems and Florida Community Care. And I really appreciate the opportunity to talk to you all today. And I'm going to give my colleague, Callie, a chance to introduce herself too.
Yeah, hi everybody. My name is Callie Wilson. I'm the program director for the ICMC program. Nice to be here. My background is primarily with APD and all of the services that are provided under the Med Waiver. I'm a nurse. I have 3 children. 2 of them have disabilities. So excited to be here with you guys today and discuss the program.
Okay, great. I wasn't sure who all would be in the audience and what your experience might have been hearing us talk about the pilot program before this. So I put together some slides, some of which, if you've been in one of these talks before, you've seen before. So I'm going to go through it quickly and then try to get as quick as we can to what's new since the legislative session and what's happening to implement that legislation, and then open it up for questions, because I think that's probably the most important part of our discussion today. But I wanted to make sure I gave you a baseline. So these are our standard slides explaining who we are as a company. I mentioned our names, but Florida Community Care is the Medicaid plan owned and operated by Independent Living Systems. And we were very pleased to be selected through a competitive procurement to be the managed care plan that was selected to implement the managed care pilot program in 2023. That legislation was passed, and I think we were selected in early 2024. It went live in October of 2024, and it was created by legislation, and the most important parts of that original legislation is that it authorized eligibility for people who are 18 years of age and older who live in these 2 geographic areas that are in orange on this map, and who are eligible for services under the I-budget, as evidenced by the fact that they are in pre-enrollment categories. And in the original version of the legislation, that was limited to categories 1 through 6. And APD was given the responsibility of kind of managing what we call the pipeline into the program. And the next slide shows you what happened from go live in October of 2024. There was an uptick in those early weeks. Each of those bars in that graph are about a week's worth of data. So we rose relatively rapidly for a few weeks, and then we've been kind of flat ever since then.
Hey,
and
Carol,
that was, yeah.
real quick, let me interrupt. Can you go to the bottom of your screen and hit the little presentation button so that
You're
it
gonna
can be
Maybe.
enlarged?
let her know which one.
I'm looking. There should be a little slide at the bottom right of your.
Did I do it?
There you go. Yes, you did.
Okay. All right. Perfect. Thank you. I apologize for being such an amateur. My excuse is I'm older than dirt, and I should have a small teenager following me around running all of the technical equipment that I have to deal with. So, all right. So that's what happened to the enrollment. The program offered a managed care model with a comprehensive set of benefits, including Medicaid's medical care coverage, the normal long-term care services that are in the Medicaid program, and all of the specialized home and community-based services that up until the creation of this pilot were only available through the iBudget waiver. This slide shows you some examples of what falls into each of those buckets, but the bottom line is we were one managed care plan and we were offering all of those services through a single delivery system. This slide shows you the more specific list of services. So that'll be useful to you when Dina actually sends you out the slides. And because we were selected through a competitive procurement process, we also made an offer to the state to provide extra services above and beyond what they were actually paying us and requiring us to provide. Those are called expanded benefits, and we offer expanded benefits in each of the 3 benefit categories that I just described to you. MMA or medical coverage, we do extra things there. We do extra things in long-term care, and interestingly, we provide several great services as an expanded benefit for the IDD population in particular, including summer camps, caregiver transportation and supports, recreational therapy, a variety of things. And so the details of that are also in the slide presentation. I'm not going to spend any time going through that, but they'll be available to you as a reference when we send out the slides. We assign a care coordinator to each of our enrollees, and that care coordinator serves as the single point of contact for anything an enrollee might need, whether or not it's an appointment with a doctor or medication or durable medical equipment or placement in an adult day training or a group home. Everything that's covered in the benefit package all happens through that interaction between our care coordinator and the enrollee. And therefore, it's very important that as part of our contract, we made a commitment, and we are now obligated under the terms of that contract to maintain a care coordinator to enrollee ratio of no greater than one care coordinator to every 18 enrollees. So that's a very low ratio, but it's absolutely essential to our program model because the care coordinator is responsible for all 3 of those buckets, so really has to be available to the family a lot of time and for a lot of different needs that they may have.
Hey, Carol, one quick
yeah.
question. Does the care coordinator do home visits?
Yes. In fact, we again have another contractual requirement where once a person comes into our plan and becomes enrolled in our plan, we have to go make a face-to-face visit with that individual within 5 days, that individual and their family or their caregivers or whatever, and develop a person-centered support plan, do a complete assessment of their needs, and start to work on what their plan of care is. So after that, after that initial visit, we're required to have face-to-face visits at least once every 30 days. But I think, especially in these early days, it probably is happening more frequently than that because the families are getting used to what's in this managed care model, and the care coordinators are getting to know them better. And there's a lot of reasons why that very active, frequent visit schedule is happening in the early days. But it has to happen at least once every 30 days. So from a provider perspective, you may be interested to know that when if in fact you start participating as a provider in this program and we place an individual in your programs or in your facility, our care coordinator will be visiting with you a lot. You'll get to know that person very well while you're serving our enrollees. Again, this will be a good reference for you when we send out the slide presentation. This is our website, and you can see where a lot of other information is available to you on this website. Member is circled because I must have last used this slide with a group that had families in it, but you'll see that there's a tab for providers, and you can learn more about our process and express interest in connecting with us if you're so inclined. So that's how things started based on the legislation from 2023 and the implementation that began in October of 2024. But you could see from that enrollment slide that I showed you earlier that we did run into some problems. Primarily in that pipeline was very slow. The communication out to families was very limited and oftentimes confusing. And so we didn't reach as many people as we had hoped to, and that we have the capacity to. And the legislature took a look at these things and passed a bill to try to smooth out the operation of the pilot. Importantly, they expanded the pilot in 3 phases, and I'll show you a timeline in just a second of what those phases are. They emphasized and strengthened the statutory language for persons with IDD to be voluntary participants in Florida's managed care system, and specifically in this pilot. That was an important point because at the same time the pilot was getting started, the Agency for Healthcare Administration changed their policy regarding how they treated this population in regard to regular Medicaid, just kind of the medical services that you might get if you enrolled in a plan, and they made it an opt-out system of voluntary choice rather than an opt-in. And that confused a lot of people, worried a lot of people, upset a lot of people, and was very disruptive. And the legislature said, no, it has to be voluntary. It has to be an affirmative choice. So that is true for the pilot. It's true for all of Medicaid managed care in Florida. The legislation went on to clarify the roles of AHCA and APD and specifically place the administrative responsibilities in the hands of AHCA and directed AHCA to operationalize the program as if it was just a part of the Medicaid managed care system. It also directed AHCA to develop partnerships with community organizations so it could do a better job of getting information out to families about the availability of this choice. And then it did some other things regarding operations of APD, regarding the iBudget waiver, which are listed on this slide. And we can talk about if you're interested in, but I'm going to skip it for now because it's not specifically related to the pilot. This is the timeline that that House Bill 1103 directed to happen. And so as of July 1, 2025, this past July 1, the legislation became law because the governor signed it. It became law. And the first thing that happened was it removed that limit to on the wait list categories. Previously, they'd only been categories 1 through 6. Now they're all 7 categories. So the wait lists are eligible to choose to join this pilot program. So it also authorized the creation of a participant-directed option. That's the terminology that's used in the long-term care managed care program for the option that is similar to CDC or consumer-directed care in the iBudget. And it basically allows families to take a more direct and active role in selecting the services that are going to be provided to them in their home and managing those. The legislation also directed the agency to amend the federal, seek approval to amend the federal authority and to, as of October, make the pilot available to anyone statewide. So it eliminated that regional restriction that was in the original version of the pilot. And then it also created the final phase of expansion is slated for July 1, 2026. And at that point in time, in addition to the pilot being available to anyone anywhere around Florida, it also would allow people who are currently enrolled and participate in the iBudget waiver to choose to move over to the pilot program. Whoops, sorry. I can't do it. There we go. Okay. This is a timeline that AHCA created for their activities. I want to, we have met with AHCA numerous times since the legislation went into effect, and they have described for us what they're doing to try to implement it, and even allowed us to suggest to them some ways that they might do that more effectively. So they are working first about focusing on having the new legislation go into effect for the existing regions, that is Region D and Region I, those places on the map that we saw earlier. And when the pilot first started back in 2024, APD sent out letters to people in those geographic areas that were on their wait list. And they were explaining the availability of the pilot, but they were also explaining a number of other things. It was a little bit confusing, but on that basis of that letter, people were able to say, I'm interested. So AHCA is now treating that whole group of people in two groups. One is the people who said they were interested, but then somehow or other that didn't progress to actually any further action on their potential enrollment in the pilot. And the second group is the people who didn't respond to that mailing at all. And they are starting this month in August to actually conduct outbound calls from their call center to those individuals to contact them. The reason that that's a priority group to contact is because we know they have Medicaid eligibility, we know they have some interest in the pilot, and we know they're already living in the area that would make them eligible for the pilot even before the feds give us permission to expand it statewide. And they will also be mailing letters to people who expressed interest, but those letters are a bit better than the APD. They're more clearly written. They have a QR code on them, so you can jump to a website if you're looking at them. And they give an individual a PIN number so that they can be associated with a record that is sustained through multiple contacts with the call center. Anyway, they hope to actually have that expanded enrollment available for D&I as of September 1. And October 1, they're hoping that they can begin getting to additional, that they'll get the federal approval for the waiver expansion and they can go to additional populations. And this is some of the other steps in AHCA's outreach timeline. They're training their staff. They're, going to send out postcards and letters and have dedicated staff inside their call center who have been specifically trained to talk about this program. So hopefully the communication will be much easier and more effective for families. And so this is what we call a heat map, and this is what we know from APD's data about where people on the wait list reside. And so we've been using this and trying to anticipate where we might see the greatest potential for additional enrollment. Okay, that is a very quick overview of a lot of information. I'm gonna stop sharing, let Callie add anything to it she wants, and then be
Well, I'm
available
gonna-
for questions if that's okay with you, Dina.
That's perfectly fine. I know we've got several questions in the chat.
I've actually been copying them and pasting them, so I'm more than happy to go ahead and just give them to you, Carol, and you can answer, I can answer whatever. So the first question that I wasn't able to answer, will there be an individualized cost plan? And how will hours and services be determined?
Yeah, so this is really an important question because it gets to the heart of what's different about this program versus what you might be used to in iBudget world. In iBudget world, everything is governed by that cost plan, as you know. In our managed care model, we have a care plan. We don't expect or ask our care coordinators and our families to make dollar-driven choices at an individual enrollee level. They're supposed to be focusing on what the needs of that family are and deciding what types of services and what's the frequency of services, level of services, all of those things, working that all out in a care plan. And that care plan ultimately serves as authorization for almost all of the benefits that someone gets by being enrolled in this program. There's a few other things, especially on the medical side, that might require prior authorization. But for the most part, that plan of care, and it's just talking about services, not dollars, is what gives them authorization. The way it works in our system is, as a managed care model, we hold the risk for working within the funds that are provided to us, and we manage that on an aggregate basis, not on a case-by-case basis. So nobody's ever going to be told, oh, no, we've already spent too much money on you, you can't have something else. That's just not the way it works.
All right, next question. Does FCC get to keep or receive back any percentage of the money not spent?
FCC is paid on a capitated basis. For each enrollee, we receive a specific amount of dollars per that member per month. And we're responsible and monitored in a variety of ways for making sure we meet their needs. At the end of the day, if in fact we've met people's needs, we've achieved all of our contract requirements, we've met everyone's needs, if there is money available after that, then FCC has the ability to make some profit, but there is a cap on that profit. We are not automatically awarded that amount of money. It's simply the maximum amount of profit that we could retain. It's called the Achieved Savings Rebate, and I can talk about that in more detail if you're interested.
Okay, so we'll come back if we need to. Will QOs be eligible to serve or be recognized as providers independent of APD?
So at the moment, all of our care coordinators are employees of our company. But going back even to the application we submitted during the competitive procurement, we proposed that we test out two models of care coordination, one using employees and one using contracted organizations or individuals. So we never got permission to do that. We've talked with the agency a couple of times, but at the moment, the terms of our contract don't allow us to enter into contracts with qualified organizations to be our care coordinators. I expect that to change at some point, but that's the first threshold, is they'll have to allow us to do that. And then we'll see how we go about implementing that, selecting individuals and contracting with them to do that. But at that point, then they would be working for us under the terms of a contract to serve as a care coordinator in our managed system of care.
Okay. We have quite a few. Can a client stay with current support coordinator? So that's an interesting one. Go ahead.
Yeah, so right now, again, we are only enrolling people off the wait list. So my understanding of what happens on the wait list is sometimes individuals have APD employees who are support coordinators, but they're not very active because, again, they're on the wait list. They're not enrolled in the program. So at the moment, those individuals that have support coordinators are in the iBudget program and they're not yet able to participate in the managed care program. That choice will be available to them as of July 2026. At that point, again, for continuity of care, I would hope we would also have passed the threshold where we can contract with support coordinators in addition to employing our own staff. And so it might be possible to continue that relationship. And if I could, I'll go a little bit down a tangent. Right now, we have a responsibility for what's called continuity of care. So that is if somebody comes in and becomes an enrollee in our plan and they were interacting with a provider in some fashion before they became our enrollee. Maybe they had a little bit of private resources, they were able to pay for some services or whatever. Then we have a contractual obligation to maintain continuity of care between that enrollee and that provider for at least 180 days. And what we do during that 180 days is try to negotiate a contract so that that provider comes into our network and can continue serving that client in what is a more routine fashion for us, but similar to what they were doing before that person became our enrollee. I would hope that we would adopt a similar model when we get to the point and when we have permission to contract with support coordinators. I would hope that we could also look to try to do continuity of care. But I would say the most important thing to us there would be the individual or family choice.
What happens to clients who are using Medicare as primary health insurance and Waiver?
So we have a responsibility to coordinate those benefits, and we routinely serve people who are dually enrolled in both Medicare and Medicaid. We do that. 95% of our long-term care enrollees in our statewide long-term care plan are dual eligible. So we are very used to the administrative task of figuring out what is Medicare covering, what's the limit of that coverage, and when does Medicaid kick in to pay for additional services on top of that. So we just manage that as part of the back room of being a managed care plan.
Okay. Are services based on some predefined service package, or are services highly individualized based on clients' needs?
They are highly individualized. They are absolutely driven by that assessment that the care coordinator is going through with the family and the development of the person-centered care plan. I mean, I would say, I would put it this way. Maybe the menu is kind of set, although we have the opportunity in this model to be innovative. And we're right now talking about a variety of things that aren't fully developed yet, but a variety of ideas about how we can kind of put different situations and service providers together in different ways and be more innovative. So we at FCC are absolutely open to that. We have the flexibility to do that under a general managed care model that's probably not available when a state agency is the payer as a fee-for-service claim.
Does FCC keep Medicaid eligibility?
We have a responsibility to have our care coordinators help our enrollees maintain their Medicaid eligibility. We do that in our long-term care plan. In fact, we have staff that work for FCC that are eligibility specialists, and we work with clients, and we have been given permission by AHCA and DCF to have access to their Medicaid eligibility records, so we know what documentation might be missing and what gaps need to be resolved in order to maintain that flexibility. So we absolutely work as an advocate for the family to keep that individual enrolled in Medicaid.
So our next question's one of these, I think, that is a little more apt, is it's more involving the SMMC expansion. It says, what if individuals do not want to change over, but they have tried to opt out, but are getting the runaround on what needs to be done?
I hope that doesn't happen very often, but I'm every day amazed at kind of the mistakes that get made out there. But I feel like AHCA is doing a lot to train their staff, to make sure people know, can get to their call center, can reach a human who's been particularly trained in issues related to the IDD population, and that we hopefully will see those kinds of mistakes and problems arise less frequently. But I would say, again, what I see the FCC staff doing is advocating for families and individuals in lots of different ways. And if that means helping individuals figure out where's the exit door, we'll help them do that too, if that's what they want.
Let's see. If you choose to join the pilot program, but they want to move back to the waiver, what is the process? Do they go back on the wait list?
So I'm going to have to do a little bit of guesswork here because we haven't had this situation arise yet. The law from the original legislation that passed in 2023 created a set of provisions that speak to what if you enroll in the pilot, you try it out, and you decide you don't like it. And what that says is that if you've got cause, that is, if FCC screws up and doesn't do what we're supposed to do, that constitutes cause. You can get out at any time. And if you've been in the program for a year and you're still not satisfied with it, you can get out. And when you opt out under either of those circumstances, you are supposed to be offered a enrollment in a comparable waiver. I believe that you can only call two different waivers comparable in this situation. One is the managed long-term care waiver, which offers home and community-based services, and the other is the I-budget waiver. And so theoretically, if you meet those conditions, you should be enrolled in one of those alternative programs. If you don't meet those conditions, you can still get out of the pilot. If you want to get out of the pilot, you just go back on the wait list.
I'm going to lump the two next questions together because the answer is pretty much the same. Will providers be subject to Clarent reviews, and will they be using iConnect?
Yeah, we talked about this with folks a lot, haven't we? So
Yes.
Any provider who is serving clients that are from different payer sources. They might be serving some of our enrollees and some iBudget waivers. And under those circumstances, and for your licensure standards, for all those reasons, you're going to have to do the kind of documentation you've always been used to doing. And when Clarent comes in, they will look at your iBudget enrollees. They will not have anything to do with the FCC enrollees, but I assume you're going to want to just have those routines of keeping all of that similar documentation that you're used to doing. So we can't like tell you not to do that, but we can tell you that we don't need it for our oversight of our enrollees that you may end up serving. And you do not have to use iConnect. We have our own technical system for recording events and care and services that are provided to our enrollees. It's called eCare, and it works a lot easier than iConnect. And also, we don't use iConnect for claims processing. We have other billing systems. And if you want to get into the details of that, I'm going to let Callie tell you about that.
Okay. Is this for the client or the whole family? Go ahead.
So the enrollee is the client with the intellectual or developmental disability, but so I've been the family member of a child with complex medical needs. Callie mentioned she's the the parent of children with developmental disabilities. You can't serve our kids without taking care of our families. You can't do it. You got to interact with the families. So yeah, we serve, our enrollee is the enrollee, but we serve the whole family.
In addition to that, we do have an expanded benefit specifically for family and caretakers, which includes some assistance just to be able to speak with somebody, therapy, mental health assistance. So just for that information. Have we done an evaluation of services from the participants?
We have not yet. We are actively exploring a couple of different ways to get that done. We have a responsibility as a managed care plan to do it in certain ways for our Medicaid contract, and we've also looked at ways to do that with some using some tools that the DD Council developed. So we haven't done that yet. But we will. We will.
Yes, definitely in the process. Who are the FCC shareholders?
FCC is wholly owned and operated by Independent Living Systems. Independent Living Systems is a privately held company that was organized and developed more than 20 years ago by Nestor Plana, our founder and CEO. There are a few other, I think, critical participants in the senior leadership team that participate in that, but it is a privately held company, and the majority of stock is held by the Plana family.
This next one, and I can answer. It says, so the person starts with low number of service hours instead of number of service hours needed. Absolutely not. We definitely are starting services. Again, as Carol mentioned, it's very person-centered, and we want to make sure that the individual is getting the hours that they require. So more on that if anybody needs it. Let's see, I'm going to move on. Let's see. Does FCC have coordinators to be able to cover the entire state of Florida? Not yet, but we are hiring. So hopefully we will be able to expand our team. Is FCC the only MMA doing the pilot program?
Oh, Callie,
Yeah.
just, can I go back to that? Do we have coordinators for the whole state question? So we are actively hiring. Callie is absolutely correct on that. But we are already a statewide long-term care plan, and our long-term care plan employs people who serve as care coordinators for our mostly aged and disabled population in that long-term care plan. So if we start receiving enrollees and we haven't yet hired somebody in some corner of the state, we will have the capacity through our long-term care plan to enable them to get some care coordination services while we're developing that capacity.
So is FCC the only MMA doing the pilot program for Orange and Osceola counties?
We are. So we are the only one doing the pilot. There are other managed care plans that do long-term care. There are certainly other managed care plans that do the medical coverage portion of the Medicaid benefit, but we are the only one testing out the comprehensive benefit package that is part of the pilot.
The next question is, who are the providers and how do you become a provider? Go ahead.
So I was working with a database and we have, because we are building our network to serve the IDD population from the basis of the network that we already have in place for our statewide long-term care plan, we already have a very robust network. So I was looking at a data set and we have almost 84,000 unique providers in our network. Now, those numbers get that big because of the medical providers and because of the long-term care providers like skilled nursing facilities, home health agencies, and assisted living facilities and that kind of thing. And a much smaller number of them obviously are the specialized providers of IDD services. But even just in this short period of time that we have been operating since October 1 of 2024 as this pilot program, and just in those two regions, we already include in our network 2,624 providers who are APD certified. And about 1,700 of them are located in those counties in those two regions. So that suggests that we even have another almost 1,000 APD certified providers who are in neighboring areas. So network development and provider recruitment is a constant activity for our organization. So those numbers never stay solid for very long. They are changing constantly, but I think that demonstrates that we have the capacity to contract with a very robust group of providers.
Just before I go on, I just want to make sure everybody understands. I don't know if we'll be able to get to all the questions, and if we can't by time up, we will make sure to answer all the questions and email them out to everyone. So I just want to make sure everybody understands that we'll definitely get all of the questions answered.
Yes.
The next question, how will you be able to transfer over CDC Plus clients?
So, as I mentioned in the amendment to the waiver that AHCA is now in the process of trying to get approved by the feds, they will get that authority for us to offer what's called participant-directed option. While the design of the PDO program as opposed to the CDC program is slightly different at its heart, it is putting an individual or their designated representative in charge of, say, hiring personal care workers or direct service workers, all of those kinds of services that are delivered in the home can be managed by that individual representative. It happens a little bit differently because in CDC, I think APD ends up paying the claims based on the direction from the family member. And obviously, we would pay the claims again in response to that representative or that individual selecting a particular provider or source of care or that kind of thing. So I think we would just work with the family to find out what they had previously arranged for in CDC and try to develop that as much as possible in a similar fashion under the PDO policies.
Are we only targeting individuals who are over 18 and on the wait list?
Yes, those criteria are included in the legislation, in the law, so that's all we can do for now.
Are care coordinators support coordinators? What are care coordinators' qualifications?
Callie, you want to take that one?
Yeah, absolutely. So the care coordinators are our internal full-time staff. They're hired by Florida Community Care. And then as far as the qualifications, what I can do is I can actually, I'll search while we're on here for the job posting that we have online, and I can just put that in the chat. So I'll put that there. Next question. What happens with nonprofit ADTs? Will clients still be able to come to our program, or would the ADT have to be employed by FCC?
No, all of the providers that we work with, we work through a contractual relationship. So whatever your organizational structure is, there's no reason to change that. You would simply be entering into a contract with FCC, and we would agree to pay you for certain kinds of services when you submitted claims for those services.
Our next question comes from our lovely Kathleen Border. Can providers be involved with larger discussions in some sort of committee or advisory group?
Yes, please sign up now. We have been working with a small group of stakeholders that includes AHCA Florida and several others, and we would look to that core group to help us develop some committees. But we have for a very long time said we need advice, input, insight, and expertise that the providers have to offer.
The next question is about tiers. How many are there? What's the difference between them? I'm just going to leave it at that. Go ahead.
So I'm old enough and been around the legislature and the government in one form or another to remember tiers when that was the way in which the money was managed for the IDD population. But it really is not, we don't have any tiers. So what we have is a one size fits one person-centered support plan, and that determines what types of services, how much of them, what the source is, what the frequency is. It's what does that one person need, and that is developed by the family and the care coordinator in conjunction with each other.
Will the iBudget waiver be phased out?
So there was absolutely no discussion of that or consideration of that in the past legislative session. The iBudget waiver is created by legislation, and no legislature can bind future legislature. So I am not going to promise you forever and ever. But here's what I know after 20 plus years of working for the legislature or as staff and so forth is elected officials respond to their constituents. And their constituents, many of them are telling them when they get the I-budget waiver that they're satisfied with a lot of the aspects of those programs, and they don't want it to go away. And the members of the legislature hear that and are sensitive to that. But what they're also trying to do is find a way to serve people on the wait list. And they had the experience of more than 5 years in a row, they allocated new money to APD to enroll more people. They spent more than $200 million and enrolled only about 1,200 additional people. And the legislature wasn't satisfied with that. And the pilot was created as an alternative model to the I-budget, because whatever barriers there are to serving people inside the I-budget system seem to be not fixed just with money.
Okay, so I think we only have a couple minutes left, and I know Dina probably wants to talk. I believe we have more than about 25 more questions. So I think we'll just have to, we'll definitely get an email with answers to the questions to Dina as soon as possible. Dina, did you want to say anything?
I was just going to say that, yes, we want to be conscious of time, but we will send out the answers to all these questions when we send out the presentation. We will include Callie and Carol's email so that if you have more detailed questions, you can reach out directly, because I know there's still a lot out there that's unknown, but we certainly appreciate, as always, Carol and Callie sharing their wisdom and information. And we will get this out. Not a problem.
Good. Well, thank you, everybody. Really appreciate it.
Thanks, everyone.
Thanks so much. All right.
Thanks. Bye.